Hello, I'm Robert McMullen, MD. I'm a psychiatrist in New York. I went to Georgetown Medical School and Columbia for psychiatry, and I've been in psychopharmacology for about almost 40 years. And 10 years ago, I started using TMS, transcranial magnetic stimulation, a new modality to help with treatment-resistant patients. What I'd like to talk about mainly today is new developments in treating depression, and particularly high-dose thyroid hormone and TMS. And I'll tell you some personal things about myself that might make those treatments a little more interesting. But first, I want to talk about some more minor things. The newest thing that is out is S-ketamine. As you probably know, ketamine injections have been used, their IV infusions have been used for depression with significant success, often bringing people that are severely depressed for years to normal in an hour or two. But it doesn't always last that long, and then one needs to go in and have an infusion every 2 weeks, and it's quite expensive. Over the years, I used ketamine as an inhalant. A compounding pharmacy would obtain the ketamine and put it in a container, and it was measured for how much you would obtain, and that worked out better because people could do it at home and they could titrate the dose to a smaller dose than an infusion and do it every day or every other day. This S-ketamine, E-S-K-E-T-A-M-I-N-E, is available now or about to be available on prescription. It's probably going to cost a fortune unless the insurance pays for it. If you add naltrexone to it, a study showed that if naltrexone is added, which is a narcotic blocker, it significantly increases the efficacy of this. Now, something else is new is very low-dose lithium. 50 years ago, or more, there were studies showing that 900 milligrams of lithium would help depression. That's a pretty hefty dose, and you often get significant side effects with that. Somebody who's manic depressive might take only that amount, or 1,200 or 1,500. And in recent years, many of us have been astonished that 150 milligrams often works for depression. I have 60 people in the last 4 years who had a significant benefit within 2 weeks, and the benefit persisted. And a few others who we are pretty sure it has helped, but it took months, and so you can't say for sure. The other thing is that it greatly reduces the risk of Alzheimer's, and it actually slows down aging. Those of us that suffer with depression have double the risk of Alzheimer's, and Alzheimer's is very common anyway. Those who are fairly bipolar, they have 7 times the risk. And in both these groups, the lithium apparently lowers the risk to about the same as the rest of the population. This was found, interestingly, because certain areas of Texas had rather low Alzheimer's rates and also low rates of suicide. And somebody finally noticed that it was the areas that had a lot of lithium in the drinking water. There's only about 1/3 of a milligram per day in the drinking water, the way I calculated it. So even 1 milligram per day probably is prophylactic for Alzheimer's. If somebody has no mood disorder, I suggest they take at least 5 milligrams a day. You have to obtain it on the internet as lithium orotate, O-R-O-T-A-T-E, a different salt, but it's the same thing. But if anybody has a history of a mood disorder, I think they should take at least 150 milligrams, 150. The way it slows down aging is very interesting. As we age, the ends of DNA called telomeres break off. And as they break off, I guess the DNA doesn't work quite as well, and that's part of aging. Lithium repairs these telomeres and also prevents more from breaking off. So it appears that your aging skin and other things that we like to keep nice will not age as fast. I'm not sure of all the evidence on this, but theoretically, this is what happens. A couple of other things I want to mention quickly is people forget about adding a little Wellbutrin, bupropion to serotonin medicines. And they're two completely different type of antidepressants. So sometimes just a small addition of Wellbutrin will help. That's been known for quite a while. But fish oil is something that's also overlooked. You really need to take 2 grams of EPA, at least, for depression. It was discovered in 1999, or proven in 1999. And I gave it to a psychiatrist at that time who had chronic, fluctuating mild depression, and he became normal. It was very dramatic. And then about a year later, he came in and he was mildly depressed again. And just like he'd been before. So I was going, he'd been depressed about a month. So I was going down his medicines, and then I asked him, well, what about the fish oil? And he said, oh, I stopped that. And I said, when? 6 weeks ago. So obviously, his stopping it had something to do with his depression coming back 2 weeks later. It's amazing how people forget about efficacy and so on of something they've had. I have that all the time with TMS, that people do terrific, and then a couple of years later, they say, oh, it never really helped me that much. Because maybe they stayed really well for a while, but then they gradually went back. Anyway, I have one fellow on fish oil that takes 18 pills a day since 1999, which is 21 years. And if we go down to 10, he immediately gets mildly depressed. So a high dose is sometimes necessary. Now, I want to talk about a couple of personal things which will give you some insight into using thyroid and TMS. My wife is very private, and she never likes me to talk about anything personal to anybody. But she can't stand listening to me, so I'm sure she's not going to watch these videos. She should listen more. She could learn a lot, but she is tired of hearing me. I'm just afraid one of her friends will tell her about this video. One example of how she got upset is I went to a dinner conference, which they don't do anymore because it's unethical to take your spouse or something. And the government's not too ethical, but the doctors have to be. And I was sitting there taking notes and learning, as well as having some nice food. And then I went home, and she was furious. She said, how could you do that? How could you be disclosing such personal things at a dinner like that? A drug rep had called her up about this, and I couldn't figure out what she's talking about. I said, I sat in a booth all by myself taking notes on my computer. And she says, well, what about the sinusitis? I forgot about that. He had said the side effect, this one bad side effect of this medicine, it's no worse than having sinusitis. So I stood up and I said, well, you know, the sinusitis can be sort of dangerous. That my 18-year-old daughter died of sinusitis when it went into her brain and spread through her brain, herniated her brain, and she died in a day and a half. And this used to happen a lot prior to antibiotics. And I was just saying that just to, doctors like to educate other doctors and mention things that are important, and I'm sure those doctors still remember what I said. the drug reps were very upset, and they thought he said something inappropriate, and he didn't say anything inappropriate. But anyway, my wife was so upset about this. It wasn't her daughter, it was from my previous marriage. But anyway, so I have a tendency to do that. So with thyroid hormone, in 1990, Weyer and Weibrow, two fellows from Germany who have mainly been in this country, they did a study where they showed that super high dose thyroid helped depression. And this was in bipolar depression, people that were rapid cycling, but it also works in people that are not particularly bipolar or only slightly. And 8 out of 9 of their patients had a dramatic response when they went up to 400 or 500 micrograms of T4, called Synthroid, levothyroxine. That if you're giving a little boost of thyroid to somebody for depression, you might add the equivalent of 100 micrograms. Going up to 400 or 500 is really high, and it drives the endocrinologist crazy because it drives the TSH way down. But we're not using it for their thyroid, we're using it as an antidepressant. Jack Gorman, I think around that time, and other people did a study where they measured the transthyretin in the spinal fluid. But the transthyretin is what moves the thyroid hormone from the bloodstream into the brain. And they found that the transthyretin was really low in most of the people with depression, which would be an indication that their thyroid is low in the brain. So the idea is give people a very high dose of thyroid so that more will spill into the brain and it will help their depression. Now, I've had depression for 32 years, and for the most part, I've done really well just on antidepressants. And then I had a little more a while back, and so my doctor and I were adding in the cytomel. And I went to Tokyo to give a lecture on TMS, which went well. And after that, I lost all my medicine, leaving it under the sheets in a hotel, and the hotel couldn't find it. And I promptly went into such a depression like I've never had. I slept 20 hours a day. I didn't have enough energy to go down to the dining room to eat. I had to order up, and my wife was really aggravated because she hates going around these subways in Tokyo where nobody speaks English, and the signs about where to go for a certain train are just little signs in English. So it was much easier with me, so we could both worry about where we're going. And I tried to get medicine, and I couldn't get any of the medicine, and we had it shipped to us Federal Express, and the country wouldn't let it in. And even if they were abusable medicines, how am I going to sell 10 pills each of abusable medicines? Anyway, finally, I was able to get cytomel thyroid, and I quickly went up to 125 micrograms instead of 50. I went to 100, and within a day, I was out of the depression. It was astonishing. And now that's my main antidepressant. My pulse went too high for 8 months if I went above 75. And then now I'm up to 150 and no problem. And my pulse is 80. The one thing you do when you increase it is check your pulse to make sure it doesn't go above 100, and then you stay lower. The main risk in older people is that it could cause atrial fibrillation. But when you're older, atrial fibrillation is common, so you're not sure whether the thyroid contributed. I just talked to a woman today, and as we went back up on her thyroid, she's only done well on 4 pills of 60 milligrams of Armour thyroid. That's the only time she's not depressed and functioning. But the level for her thyroid to be normal on the lab test. It's just 1 pill, not 4 pills. And we were going back up on it because the endocrinologist was lowering it and she was getting worse and worse. And so she has atrial fibrillation, but her pulse was fine. And she's had atrial fibrillation before, unrelated to the thyroid. So anyway, it's a difficult decision of what to do that she has to make. Now, this doctor, will show you a picture of the book he wrote, Tms Kelly, on this high-dose thyroid. He likes to use T3 Cytomel instead of T4 Synthroid for a very good reason. The half-life of Cytomel is 1 day, so in 5 days you're at a steady state. And so once a week you can increase the dose if the pulse stays below 100. And then in 4 or 5 weeks you can be up to a really substantial dose. When you use Synthroid, the half-life is about a week, so the steady state is not until 5 weeks. So you can only increase the dose every 5 weeks, because if you increase the dose at 3 weeks, and then he or she starts getting side effects, you don't know whether it's because of the added thyroid or if they just stayed at that other dose, which is still slowly going up, that they wouldn't have had the problem. It makes it complicated. And also, if you do have atrial fibrillation or just too many side effects with Cytomel, you can just stop it for a couple of days and the dose will go way down, the level will go way down, whereas Synthroid, it can take quite a while. And one of my friends put somebody up, quite an older man, up to a high dose of Synthroid, and he got atrial fibrillation. But then stopping it, it's going to take 4 or 5 weeks for the level to get really low. Now, one other thing I want to mention, and there's a slide on that we'll put up here in the lecture, and that's what should the thyroid level be just under normal circumstances. When the TSH is high, that means the thyroid is low. So we always thought that a TSH of 4 or 5 is a cutoff. If it goes up to 10 or 80, and I had a patient a while back who had a level over 200 because he stopped his Synthroid, then that means your thyroid is low. And the lab sheets still say this. But the American Thyroid Society and also the American Chemical Society, which probably has to do with laboratory tests, both said a few years ago that the cutoff should be 2.5. And psychiatric research comes down to the same number. Studies show that the biggest predictor of people who will not respond to treatment with medicine is having a TSH above 2.5, exactly the number they came out with. Now, the reason they came up with this number of 2.5 is most bell curves are smooth on both sides. If you do all the heights of somebody in a population or something like that. But with the TSH, it goes up high for most people, but then as people, then there's as it comes down, where the levels of it are higher, it spreads way out, and especially among elderly people, the older people. And so that means a lot of these people are actually low in their thyroid, but they're averaging them in to come up with this number of 4 or 5. And if you just look at the peak, you can see that most people are below. Pardon?
Of the chart?
Yeah, the chart where you took the photograph. Mm-hmm. You want me to try to put it up here?
Yeah.
Okay. Yeah, this is the normal bell curve, but this is the curve of the TSH, and especially in elderly people, but you can see it's skewed way out here, And that's because these people are low in thyroid. So averaging them in makes the cutoff much higher than it should be. So, and as I may have mentioned, now this very high dose cytomel I'm on is really my main antidepressant, and it works quite well. Now, the other thing I want to talk about is TMS. Now, TMS, transcranial magnetic stimulation, works in a huge proportion of the population. Interestingly, it doesn't work in people who have no cognitive distortions when they are in their depression. And I've had a couple of dramatic cases of this, and it's also true for me. Most people, when they're depressed, they have low self-esteem, they feel guilty about things they did, they blame themselves, they're negative in a number of ways. The depression is causing them to do some distortion of reality. And every psychiatric illness does this. With anxiety disorders, you may know that your panic attacks are what is causing you to be fearful, but you're just a little more fearful of things in general. Now I'd like to talk about TMS, and I'd like to talk about some of the new developments which are quite interesting and also are going to make it so we're able to bring more people to a normal mood. One interesting thing I'd like to mention first is concerning cognitive distortions. In every psychiatric disorder, there's cognitive distortions. Now, somebody who's manic or has schizophrenia, they really have cognitive distortions because they might hear voices or have delusions or something like that. But with milder disorders like severe anxiety disorder or panic disorder, they also have cognitive distortions. They may understand that the panic attacks is what makes them afraid of flying an airplane or getting into a crowded elevator. But still, the fact that they have all this anxiety makes them a little more fearful of the world in general. It's going to cause them to be, and it's also definitely causing a cognitive distortion with the risk of getting into a crowded elevator or an airplane. Now, Jonathan Downer pointed out that in rare cases in depression, there are no cognitive distortions. I had one fellow who graduated from an Ivy League school and then was a middle school teacher, and then developed in his late 20s severe depression. And it became very severe. And he had multiple hospitalizations, or few, and he had shock treatment and a few serious suicide attempts, and then was hospitalized for a few months at Columbia because he was so suicidal. And then they found a medicine that reduced his suicidality a lot, and they sent him to me. And I treated him 12 or 15 years, I think. And it was very difficult. He had such severe depression, he would just be inert sometimes and couldn't get out of a chair, much less leave his apartment. But he had no cognitive distortions. He didn't have low self-esteem. He didn't have excessive guilt. He, like I said, he didn't blame himself about things. He felt bad that he was so depressed and non-functional, and that he couldn't spend better time with his son, and he couldn't work and things like that. He felt bad about it. I gave him 600 TMS treatments with only mild benefit. People that don't have any cognitive distortions tend not to benefit from TMS. He had some benefit. It would keep his head above water when he was getting suicidal, and then he would come in 2 or 3 times a week. and that was good. Unfortunately, he committed suicide about 6 months after leaving here, and he moved down to a condominium near his family, which I thought was terrific and that this would really help. But it didn't. He just suffered so much. And I had another 22-year-old who'd been severely depressed from a young age, and twice, 6 months in high school and 6 months in his first year of college, his mood lifted 50%. And he made a lot of friends, he joined clubs, he made very good grades. He still felt very depressed all the time, but people couldn't see it. And then he relapsed, and I gave him about 75 treatments with zero benefit. And he would sit in his room and play video games and wouldn't leave or do anything, usually. And he said, I have an illness. And he didn't feel guilty about it. It's exactly the same thing. And most people, when they're depressed, have some distortions in their self-esteem or other things. And these two people, and likewise with me. When I dip into depression, I want to sleep a lot, but I don't have any cognitive distortions, and I'm not sure how many treatments I've had, but I think I must have had 300 TMS treatments. And if I get a few in a row, I'm a little better. I feel better if I'm down a little. But they haven't been a home run with me at all. Now, what is new in TMS? Some dramatic things have happened. One thing is that treating on the right orbital frontal cortex helps some people out with depression. And we can predict those people. If you're having some active thoughts up here about going and telling your boss what you really think of her, or of going paragliding, or doing something that's risky, or going out and taking some drugs, then there's input from here coming in that is negative and saying, wait a minute, let's not be risky, let's think about this. And then these two opposing forces come to some decision. Well, people who are excessively risk averse, they would never go paragliding. They wouldn't even try a little rock climbing if a rope was around them. And they're extremely cautious about everything. And they're usually a little obsessive compulsive, or they have that style. Those people seem to have an hyperactive area here. And a dramatic case of a cure by inhibiting this was a lady a long time ago who had severe chronic depression, and she finally decided, I can't stand it, and she took a pistol and put it in her mouth and pulled the trigger. And she lived, but she wasn't depressed anymore. And it turned out she shot off the right orbital frontal cortex above the eye. And that's what this treatment is. We're not cutting out that area, we're just trying to inhibit it. And also inhibiting here and the left orbital frontal cortex both help depression as well. So obsessive compulsive people who have depression, these are good places to treat. Now we also know that treating on the pre-SMA, the pre-supplementary motor area, we have a motor area and a supplementary motor area that's also involved in moving your hand and your legs. And then there's a pre-supplementary motor area. And Lisenby and Mantovani, I'd say a decade ago, proved that inhibiting this area helped OCD. And a recent review said that the evidence still was that that was the best treatment. I don't know about that because I don't think there's been enough comparisons. Another way to treat OCD is with the Brain's Way machine, deep TMS. It's a helmet, and the magnetic field goes in 6 or 7 centimeters instead of 2 or 3, and it's reaching the cingulate cortex. The cortex is the gray matter on the surface of the brain that does all the thinking and the moving and everything else. But there's a second layer of cortex called the cingulate cortex. Oh, cingulate cortex is here. And this area is somehow involved in OCD. So the idea of reaching that area and treating it seemed obvious, and then it ended up working. And somebody gave a sophisticated reason why they knew that excitatory treatment was going to work here. But I spoke with Yiftach Roth from Jerusalem, who invented the whole machine. And I said, how did you know whether to do excitatory treatment or inhibitory treatment? He said, we didn't know. So we did half of people inhibitory and half excitatory, and the ones with excitatory got better. And that's the way a lot of science is. It's empirical. And I think the brain's way treatment of OCD is probably better than with the other machines, and they're called the figure-8 machines. Although I think that treating depression in general, I'm not so sure that this is better. You know, they're about equal. They need to do more head-to-head studies. Now, there's one other new thing, and that's the number of pulses. What we have decided is the standard amount of pulses, whether we do inhibitory treatment or excitatory treatment, seems to be correct. So 3,000 or 4,000 excitatory treatments here is good for depression. If you go to 8,000 or 10,000, it doesn't work any better. That's what the research shows now. It used to be if I had somebody very treatment resistant, I would go to 8,000. And then if someone then got better, we would think, see, the higher amount did it. But actually, if you just stayed on the 4,000, they would have gradually gotten better. This is what the research shows. There's one exception. There's something called theta burst. Theta burst stimulation, TBS. And if you do an inhibitory theta burst, it inhibits the area underneath the magnet. And it works just as well with a 40-second treatment as with a 20-minute one pulse. And if you do an excitatory treatment, it takes 3 minutes, and it works just as well as a half-hour treatment at 20 pulses per second. Now, it's been found that if you triple the excitatory theta burst, it's called intermittent theta burst, intermittent TBS, ITBS, it is more effective. So if you do the treatment at 9 minutes, which is not terribly long, you're being much more effective than if you do it at 3 minutes. There are other things that have been found, such as doing an inhibitory treatment on the pre-SMA. That's the one I said is the treatment for OCD. If you add that to a regular treatment for depression, it makes the treatment for depression more effective. So, does that mean if we did the ITBS excitatory treatment at 3 times as long, 9 minutes versus 3 minutes, plus added the inhibitory treatment on the pre-SMA, that we would have much greater response rate than the standard treatments? It looks like this is probably true, at least to some degree. And this is very exciting because with 30 treatments, 1/3 of people come all the way to normal, sometimes for the first time in their life. 1/3 have 0 benefits, and 1/3 are getting better significantly, but then the treatment ends at 30 treatments. And obviously, if you kept treating those people, they would come all the way to, or many of them would. In the first 75 patients that we treated, we had about 60% come all the way to normal. All the studies just have 1/3 of people come to normal, but that's because they all stop at 30 treatments in 6 weeks because these studies are so expensive. We went longer. We had a number of people that went out to 50 treatments, so we weren't that far from having 2/3 of people come all the way to normal. And I think that we can bring 2/3 of people all the way to normal if we can keep doing more treatments and maybe changing from one machine to another when one seems not to be working. Another exciting thing is that if you take a stimulant like Ritalin or Adderall in the morning before the treatment, it increases the benefit. I saw a lecture on this 5 years ago that theoretically this guy said this would happen, but now it's been proven. And if you take benzodiazepines, say Klonopin at night to sleep, it reduces the efficacy. So people should take the minimum possible, or try to shift to some other agent for insomnia, such as gabapentin or trazodone or something like that. Anyway.
And also, you told me now we can do it like twice a day, a few times.
Oh, I forgot. With the TMS, there's another thing that's new, and that is doing TMS twice a day worked just as well as doing once a day, at least in this one study. So half of the people got 15 days of treatment in 3 weeks, twice a day. The other people got 1 treatment a day for 6 weeks. So both groups had 30 treatments. But the one that had twice a day treatment did just as well. This is really exciting. Just imagine, and I'm trying to do this with people, is to do people twice a day, do the ITBS 3 times as long, and to add these other treatments, other places of treatment to have an additive benefit. That's just astonishing what this could turn out to be. Anyway, thank you very much. I've just talked about very high dose thyroid, which will drive the endocrinologist, always drives the endocrinologist crazy. But if somebody's got life-threatening, severe chronic depression, it's worth the risk. At least give the patient the choice. And it works in a high proportion of people. And perhaps many of the very treatment-resistant people have this low thyroid in the brain, and that's why they're so treatment resistant. And the other thing is these new developments in TMS, which is a revolution in psychiatry. Even if you only bring 1/3 of them to normal, after you've failed many medicines over a number of years, what's the odds that the next medicine is going to make you completely normal? It's close to 0. It really is close, and studies show this. And to bring 1/3 of people all the way to normal is astonishing. And the benefit is somewhat long-lasting, but you should stay on maintenance medicine. And when you relapse, you may only need 5 or 6 treatments, not 30. Thank you very much.